afternoon, everyone. Good afternoon, everyone. Welcome to the KIMS Cuddles online session. Today we will discuss about the most important metabolic abnormality which is seen in neonates admitted to NICU, that is the neonatal hypoglycemia, and we will also see few aspects of neonatal hyperglycemia. So we will discuss the neonatal hypoglycemia under the following topics. First, we will see the definition and then the glucose physiology and the transition from the fetus to the neonate, as well as the transitional neonatal hypoglycemia, the indications to screen a baby who is a high-risk baby, and the etiology and classification, treatment of hypoglycemia, the follow-up of babies who had neonatal hypoglycemia, and the long-term neurodevelopmental outcome. So glucose is the primary metabolic fuel for the brain. There should be a continuous supply of glucose for the brain to be active. And if there is any interruption of the glucose supply to the brain, there are many changes in the brain that leads to long-term neurodevelopmental outcomes also. So severe and persistent and refractory hypoglycemia in babies is harmful for the functioning of the brain. So it is the most common metabolic abnormality seen in about 5 to 15% of the babies who get admitted to NICU. And the most common high-risk neonates who are prone to get hypoglycemia are the SGA babies, IAGR babies, and low birth weight, and large for gestational age and infant of diabetic mother babies. So among them, the incidence of hypoglycemia would be around 48 to 52%. So regular screening and monitoring for these babies is very important. So coming to the definition, there is a lack of uniform definition for hypoglycemia because it is not known like at below what certain threshold of hypoglycemia the injury to the brain starts. So, but different bodies have come up with different thresholds, with the WHO saying that the operational threshold for glucose being less than 45 milligrams per deciliter, and the American Academy of Pediatrics emphasizing the glucose levels to be maintained at least 47 milligrams per deciliter. So this is an operational threshold, like if the glucose should be maintained at least 40 milligrams per deciliter to ensure a constant supply of the glucose for metabolism to all the tissues of the body. So because of the importance of the glucose as a metabolic fuel, we understand the importance of the morbidity and mortality if hypoglycemia is undiagnosed or untreated. So emphasizing the importance of early diagnosis in these high-risk babies. According to the AAP, in the first 4 hours of life, the lowest acceptable level of glucose is 25 milligrams per deciliter. If the glucose value is between 25 to 40, then we can give one feed and then recheck the glucose within the next 30 minutes. But the recommended value should be maintained more than 40 milligrams per deciliter. From 4 hours to 24 hours of life, the acceptable actionable range is between 35 to 45 milligrams per deciliter, and the recommended value to maintain the blood glucose is more than 45 milligrams per deciliter. According to Pediatric Endocrinology Society, they have given a little bit more higher cutoffs, like blood glucose less than 50 milligrams per deciliter, that is 2.77 millimoles per liter in the first 48 hours after birth. And after 48 hours, the threshold is more than 60 milligrams per deciliter. And these values are 10 milligrams per deciliter higher if the babies are at risk for a congenital hypoglycemia disorder like Beckwith-Widman syndrome, Turner syndrome, who are more prone to have hypoglycemia. Coming to the fetal to neonatal transition. So when the baby is within the womb, the baby will continuously receive the glucose by a process of facilitated diffusion from the mother through the umbilical cord. The mother also increases the stores of hepatic glycogen, so as to facilitate a continuous flow of glucose to the baby's blood. So the infant does not have a chance for hypoglycemia, and the insulin levels in the baby maintain according to the blood glucose values. So once the baby is born, the umbilical cord is cut, and then there will not be a continuous supply of glucose to the baby. So now what should happen? The insulin secretion should be regulated, and if the baby is prone going into hypoglycemia, there will be production of the counter-regulatory hormones like cortisol, glucagon, growth hormones, and catecholamines. So if there is a lack of immediate feeding after delivery, the baby maintains the blood glucose supply by various adaptations like glycogenolysis, gluconeogenesis, lipolysis, and ketogenesis. So the glycogenolysis begins immediately within the first 8 hours, and then later followed by the gluconeogenesis and lipolysis by 24 hours. So after the ketogenesis, the ketones such as beta hydroxybutyrate and acetoacetate are produced, which can be utilized by the brain as an alternative fuel source. So for this glycogenolysis, the baby should have sufficient hepatic glycogen stores and the lipid stores. These will be accumulated like liver glycogen and lipids in the body are accumulated in the last trimester, that is after the 26 weeks, between 26 to 36 weeks only, the accumulation of the body fat and as well as hepatic glycogen stores will be there. So that is why any baby who is born preterm will have less number of stores and are more prone for hypoglycemia. So early breastfeeding also supports the baby for this postnatal adaptation, because the colostrum is rich in protein and free fatty acids, which can be utilized for these above pathways. So why this transition occurs? This is probably to adapt the neonate to the intermittent supply of the glucose by intermittent feedings, that is every 2 hourly feedings, and is a method of postnatal adaptation to the survival to periods of absent glucose supply. So that is the main reason for adapting the baby to this postnatal transition to hypoglycemia. So this is the pathway for production of the ATP. So after ingestion of any food containing carbohydrate, the glucose by the process of the glycolysis enters into the citric acid cycle, and then the ATP will be produced. Suppose a continuous supply of glucose is not there, then glycogenolysis as well as the gluconeogenesis and the lipogenesis help in providing this glycerol as well as glycogen, and through gluconeogenesis it can help to produce the ATP and can help to maintain the energy state in the body. So glycerol can enter into this pathway and provide the fuel for the citric acid cycle, and fatty acids can also be a source of nutrition for the brain, as already discussed. So now coming to an entity called transitional neonatal hypoglycemia. Because of this transition from the at the time of birth, so there is a drop in the blood glucose levels. So this is normally seen in up to 10% of the newborns. But the severe level, it should not go into hypoglycemic level. So that occurs because of the inefficient production of the lactate, ketones, and free fatty acids by inefficient functioning of the above pathways, which we have discussed, like the glycogenolysis, gluconeogenesis, or the ketogenesis, which happens inefficiently, and relative hyperinsulinemia, which persists in some babies like preterm babies and SGA babies. So the transition which should happen normally, like the drop in the insulin level and the rise of the counter-regulatory hormonal level does not occur in a robust fashion in some babies, leading to the transitional neonatal hypoglycemia. This is seen in 10% of the normal newborns also, and also in babies who are having limited stores of glycogen, like low birth weight babies. So values can be as low as 30 milligrams per deciliter in the first 1 to 2 hours of life, but this can be asymptomatic and then subsequently increases to more than 45 and stabilizes at a mean level of 65 to 70 milligrams per deciliter by 3 to 4 hours of life. So this transitional neonatal hypoglycemia is depending on a variety of factors like baby's birth weight, gestational age, and the feeding status. If the feeding is given immediately, that helps in maintaining the blood glucose level, as we discussed about the benefits of colostrum, and the conditions which increase demand like sepsis and asphyxia. And it also occurs secondary to other conditions like hypopituitarism, cortisol deficiency, hypothyroidism, and in conditions of inborn errors of metabolism, such as maple syrup urine disease, hepatic glycogen storage disorders, galactosemia, and hereditary fructose intolerance. We will see the approach to these different disorders in the coming slides. So coming to the screening of high-risk infants, do we generally screen all newborns for hypoglycemia? No. So generally we don't screen term babies who are immediately getting shifted to mother side and getting established on mother's feeds. We don't need to screen those babies. We only need to screen babies whose birth weight is less than 2000 grams and gestational age less than 35 weeks. That is late preterm babies and low birth weight babies, as well as the small for gestational age babies, IDM, large for gestational age more than 4,000 grams birth weight babies, and IUGR infants. So, but in our unit, we are screening any baby who is born less than 37 weeks and less than 2,500 grams also, because they come under the low birth weight and premature category. And babies with mothers having RH negative blood group, they are also more prone for hypoglycemia, so they need to be screened. And any sick baby admitted in the unit secondary to perinatal asphyxia, polycythemia, sepsis, shock, meconium aspiration syndrome, they all increase the metabolic demand of glucose as a fuel, so leading to hypoglycemia. So we should screen them periodically, at least every 6 hours. And any family history of genetic form of hypoglycemia, if we have any history like that, we should screen them. Beckwith-Widman syndrome, midline facial malformations, and microphallus. So all these conditions, if we note at birth, then we should write the screening for them. And any neonate who is on total parenteral nutrition, regular screening of blood glucose. And in babies with mothers having conditions like hypertension or preeclampsia, mothers receiving medications like terbinafine, propranolol, labetalol, and oral hypoglycemic drugs, we should definitely screen such babies. Screening is generally not required for term AGA babies, but if they show any symptoms of hypoglycemia like lethargy, poor feeding, so jitteriness, but then we should definitely screen. So these are the neonates in whom we should exclude persistent hypoglycemia before discharge. That is, any severe hypoglycemia, that is episode of symptomatic hypoglycemia or need for intravenous dextrose to treat the hypoglycemia, inability to consistently maintain the preprandial glucose concentration more than 50 milligrams per deciliter up to 48 hours of age, and more than 60 milligrams per deciliter after 48 hours of age, and any family history of genetic form of hypoglycemia. The Pediatric Endocrinology Society endorses that we should rule out persistent hypoglycemia in such infants before discharge. So coming to the schedule for screening, so generally we should screen these at-risk neonates at 2 hours of life, and then 6 hours, 12 hours, 24 hours, and 48 hours, up to 72 hours in neonates who are exposed to maternal medications, and small for gestational age and IUGR babies. According to AAP, the screening is done only up to 24 hours, but prolonged screening is also helpful to rule out late hypoglycemia in small for gestational age infants. In babies who are admitted in NICU, sick babies, as we previously discussed, and babies who are on TPN, it's better to screen them every 6 hourly. Coming to the signs and symptoms of hypoglycemia, the most common symptoms which are associated are jitteriness, which occurs in up to 50% of the babies with hypoglycemia, followed by lethargy and poor feeding, which is seen in 30 to 40% of the babies. The other symptoms are sweating, pallor, tachycardia, tachypnea, apnea, and tremors. So these are the autonomic symptoms, also called neurogenic symptoms. The other is the neuroglycopenic symptoms. These are secondary to the decrease in the glucose as a fuel to the brain. So they are hypotonia, lethargy, altered sensorium, seizures, weak suck, abnormal cry, weak high-pitched cry, hypothermia, and in rare cases, cardiac arrest. This is seen in about 1 to 2% of the babies, the most common symptom being the jitteriness and poor feeding. So whenever we are testing, we do the point of care reagent strip method. So that will give the immediate random blood glucose value. If we get any hypoglycemia in that, then we should confirm it with the laboratory value. So the lab value should be tested immediately. If it is tested after a prolonged period of time, it may lead to the false positive value, that because the glucose falls by 14 to 18 milligrams per deciliter per hour if in stored samples, so it should be tested immediately. Always the whole blood sugar values are 15% lesser than the plasma values. So the method of testing by these reagent strips is the glucose oxidase method. So whenever a baby is having a persistent hypoglycemia refractory to the treatment and reading increasing GIR, then we should send the critical samples. The critical samples are the serum glucose levels, basic metabolic panel, venous blood gas to look for acidosis and lactate levels, and insulin and C-peptide levels, growth hormone, cortisol, free fatty acids, beta hydroxybutyrate levels, and lactate, ammonia, acyl carnitine profile, pyruvate, and urine organic acids, mainly to rule out the inborn errors of metabolism. So we will see the etiology of the hypoglycemia in the coming slides. Hyperinsulinism, either transient or permanent, is one of the most important factor causing the hypoglycemia. So the diagnostic criteria for hyperinsulinism is any detectable insulin more than 2 international units per ml in the face of hypoglycemia, and the ketone levels, beta hydroxybutyrate levels of less than 1.8 millimoles per liter, free fatty acid levels less than 1.7 millimoles per liter, and upon giving the glucagon stimulation, test rise of glucose of more than 30 milligrams per deciliter, and IGF BP1 level less than 110 nanograms per ml. So these are the diagnostic criteria for hyperinsulinism. So this is how the insulin secretion occurs. So first the glucose is transported into the beta cell by the insulin dependent transporter GLUT2, which undergoes the phosphorylation by an enzyme known as the glucokinase, and resulting in increased ATP by ADP ratio in the intracellular level, which closes the potassium channel. That results in increase in the intracellular potassium concentration, leading to membrane depolarization, calcium influx, and release of insulin from the storage granules. So any genetic defects in this pathway, like the SUR1, KR12, ABCC gene, KCNJ11 gene, all can lead to the genetic forms of hyperinsulinism. So the leucine stimulates the glutamate and helps in the release of the insulin by producing the alpha ketoglutarate, which also helps to increase the ATP by ADP ratio. So any mutations in these potassium channels or any genetic mutations here can lead to the altered secretion of the insulin, which may help lead to the hyperinsulinism. If it is produced less, it may lead to the hypoinsulinism and can lead to hyperglycemia syndromes. So coming to the metabolic actions of insulin, insulin helps in increase of cellular glucose uptake and deposition of glucose as glycogen and lipogenesis in adipose tissue, and inhibits the breakdown of triglycerides and free fatty acids. That is why in infants of diabetic mothers, when the insulin levels are at a higher level, so it inhibits the alternative fuel supply also to the brain by inhibiting the breakdown of the triglycerides and fatty acids, thereby affecting the brain functioning. Insulin is also a major fetal growth factor. So coming to the etiology, the hypoglycemia can be divided into two major broad categories, that is normoinsulinic hypoglycemia and hyperinsulinemic hypoglycemia. So in normoinsulinic hypoglycemia, the insulin level will be normal, but there will be a hypoglycemia. So this is seen in some transient or temporary conditions and some permanent conditions. The temporary conditions being prematurity and small for gestational age. Here, This happens due to decreased hepatic glycogen stores and decreased activity of the counter-regulatory hormones. And in conditions where there is increased metabolic expenditure and increased peripheral utilization of glucose, that is in sepsis and asphyxia, as well as erythroblastosis fetalis. In polycythemia, due to increased blood viscosity, there will be increased utilization of the glucose by the RBCs, thereby resulting in the hypoglycemia. Post-exchange transfusion also, there is a risk for hypoglycemia. So we should monitor the blood glucose levels before, during, and after the exchange transfusion to detect any hypoglycemia and treat accordingly. Maternal conditions like pregnancy-induced hypertension, toxemia, and use of any tocolytics, beta agonists predispose the infant to hypoglycemia. These are the temporary conditions in which insulin will be normal, but there can be a hypoglycemia. The permanent conditions being endocrine conditions, hypopituitarism, primary adrenal insufficiency. How we will know these conditions? Like if the baby is having any midline defects like cleft palate, microphallus, umbilical hernia, and so by testing for hypothyroidism, hypocortisolism, we will be able to diagnose the endocrine defects and inborn errors of metabolism, where the baby may present with after initiation of feeds, after establishing the feeds, baby may present with decreased feeding, dull activity, seizures, hypotonia, organomegaly, hypoglycemia, increased muscle tone, hypertonia also might be there. So in such conditions, family history of consanguinity, previous sibling deaths, unexplained deaths. So in those conditions, we should think of inborn errors of metabolism. Some of the examples are glycogen storage disorders, disorders of gluconeogenesis, fatty acid oxidation defects, organic acidureas, galactosemia, and hereditary fructose intolerance. So if the insulin is normal and there is a hypoglycemia, then we should think of first the transient conditions, prematurity, SGA, increased energy expenditure, polycythemia, post-exchange transfusion. If it is permanent, means we should refractory hypoglycemia, rule out the endocrine defects and the IEMs. So if the insulin levels are high, hyperinsulinemic hypoglycemia, then again it can be divided into transient conditions and permanent conditions. Transient condition is seen in infants of diabetic mothers, where the insulin level does not fall immediately after cut down of the blood glucose supply from the mother. And in stressful conditions like asphyxia and hypothermia in the peripartum or postnatal period. So there also the insulin level might be a bit high, leading to the hypoglycemia, and in SGA infants. So in SGA infants, it can be either way, normoinsulinemic also and hyperinsulinemic also. Permanent defects are the ones which we discussed previously, like potassium ATP channel defects, GLUT1 activating mutations. We have seen the pathway in which the glucose enters the cell. So there any activating mutations and glucokinase activating mutations, any syndromic conditions like Beckwith-Widman syndrome and hyperinsulinism in congenital disorders of glycosylation. So the transient hypoglycemia is the one we have seen, the transient neonatal hypoglycemia, where the values are lower in the first few hours of life, lower than accepted threshold values, but asymptomatic, which will improve subsequently. And recurrent or prolonged hypoglycemia of the blood glucose remains unstable even after treatment for 7 days. Refractory hypoglycemia is a term which is used when the hypoglycemia is persistent even after a glucose infusion rate of more than 12 mg per kg per minute for more than 24 hours. So when you have encountered a baby who has come to the follow-up with a history of decreased feeding and dull activity, so you are suspecting sepsis bar hypoglycemia, then how will you take the history? How will you approach the baby? So we will start from the anyway in an order initially from the family history. So this is the history only specifically I've written keeping the hypoglycemia in mind. But generally we should ask everything whenever we are admitting any baby with decreased feeding, dull activity, seizures. But regarding the hypoglycemia, what are all the points to be asked? In the family history, we should ask for consanguinity and previous sibling deaths to rule in or rule out the inborn errors of metabolism, and previous history of any NICU admission for earlier siblings, and the parity of the mother. So parity for this RH hemolytic disease. In primary mothers also, like if she had any previous abortions and all, the baby may be affected by the RH hemolytic condition. So parity is also very important. So in the antenatal history, any history of maternal diabetes, preeclampsia, and blood groups of the mother and baby. So any negative versus positive blood group should be noted, and any history of intravenous dextrose infusion for the mother. So this also put the baby at risk for postnatal hypoglycemia, and maternal intake of any drugs like beta blockers and oral hypoglycemic agents. Coming to the birth history, so whether the baby cried immediately after birth, we can ask the parents, and how to check for the possibility of asphyxia if the baby is an outborn. So by asking for history of any meconium stain liquor, if that was there, and any history of fetal distress or bradycardia, which was explained to them by their gynecologist, and was there any history or need for resuscitation where they have given some artificial breathing support for the baby, and was the delivery prolonged and difficult delivery. So by asking these questions, we will be able to identify whether there was any history of asphyxia in the baby. The history is not available. And the birth weight of the baby, to know whether the baby was any low birth weight, small for gestational age baby, or large for gestational age baby. And was there any history of blood sugar evaluation after birth? So, and was there any history of hypoglycemia, which was noted at that time and conveyed to the parents? So these things we should ask. And if the baby was a normal baby with no history of asphyxia and baby cried immediately after birth, term AGA baby who was given to mother side. So if this baby was brought on day 3, day 4 of life with poor feeding and dull activity, then the breastfeeding will give, history of breastfeeding will give us a clue to understand if there was a decreased feeding for the baby. Like we can ask, when was the breastfeeding initiated? What was the frequency of breastfeeding? Were there any latching difficulties, latch score, and was her lactation assessed by any lactation consultant, and what was her letdown and frequency of feeding, duration of feeding, and by checking the percentage of weight loss of the baby, we will be able to know the sufficiency of her feeds in the first 3 to 4 days of life. And coming to the actual history, whether there was any decreased activity noted and duration, and history of decreased feeding and abnormal movements, means if they are describing about seizures, the semiology of the seizures should be noted, and duration also should be noted. So on examination, we should look specifically for any signs of this hypopituitarism like midline defects, microphallus, and the signs of Beck-Whitman syndrome like macroglossia, microcephaly, omphalocele, and organomegaly is important for inborn errors of metabolism. So IDM baby features will be like baby will be relatively large baby with a small head size, because the fat will be accumulated in the shoulder regions and more of shoulder and body compared to the head. That's why compared to the body, the head will be relatively smaller in an infant of diabetic mother. Baby will also be having a hairy pinna and will appear plethoric. So IUGR baby features are like a baby will have a relatively large head, a large anterior fontanelle, absent buccal pad of fat. Baby will be having loose skin folds, long fingers, old man appearance, and having a hyper alert look. So by seeing the baby, we will know whether it is a IUGR baby or an IDM baby. So these are some of the metabolic clues for hypoglycemia. Suppose if the baby is having hypoglycemia, then the second line of investigations will be, we will be noting down the whether there is acidosis and ketones, lactate levels, and fatty acid levels. If there is no acidosis, then we will no acidosis and ketones are normal, and there is no elevation of free fatty acids also. So nothing came positive, then it can be a genetic form of hyperinsulinism or hypopituitarism or transient neonatal hypoglycemia or perinatal stress-related hyperinsulinism secondary to asphyxia or delayed cry meconium stain liquor. If there was no metabolic acidosis and the ketones were normal and there was only one elevation of the free fatty acid levels, then it can be the fatty acid oxidation defects. So in this, the if we take the proper history, and how we will rule out by doing the newborn screening test, in which there will be an elevation of the acyl-carnitine levels. So fatty acid oxidation defects can be diagnosed like that. If there was an acidosis, hypoglycemia with acidosis and elevated lactate, then it can be a gluconeogenetic defects. And if there was acidosis with elevation of ketones also, then it can be a ketotic hypoglycemia, glycogenosis, growth hormone deficiency, and cortisol deficiency. We should remember these flow charts whenever we are working up a baby for the cause of hypoglycemia. So first, we should rule out the common causes like severe systemic illness, sepsis, SGA, IDM, LGA babies, low birth weight babies. Then we should do the urine for reducing substances. If non-glucose reducing substances are positive in urine, then we should consider galactosemia, hereditary fructose intolerance, and tyrosinemia, and work up for the same. If the non-glucose reducing substances are negative, then we will check the urinary ketones and plasma amino acids and organic acids, as well as the ammonia levels. If these are abnormal, then we should think about the disorders of amino acid metabolism or organic aciduриas. So, and then do the either the tandem mass spectrometry or the newborn screening, in which we will be able to see the increase in the profile of the amino acids. So, among the urinary ketones, if the urine ketones are low, as we have discussed in the previous slide also, and plasma free fatty acid levels are the only thing that was elevated with no ketosis and no acidosis, then we should consider the fatty acid oxidation defect. So if the plasma free fatty acids also are normal, then we should consider the congenital hyperinsulinism disorders. If the urinary ketones are high and there was an organomegaly, organomegaly is present, means then we should see the plasma lactate that is also increased, then glycogen storage defects and fructose diphosphatase deficiency. These things should be kept in mind. So if plasma lactate levels are normal, then we should consider beta ketothiolase deficiency. So if organomegaly is not there, then we should see the growth hormone levels, cortisol and thyroxine levels, and then think of endocrinopathies or ketotic hypoglycemias. So first, after ruling out the common infections, we should look for the mainly the non-glucose reducing substances in the urine. If they are positive, means we should consider the galactosemia, all those things. Then look for acidosis and free fatty acid levels. If there only free fatty acid levels are elevated, think about fatty acid oxidation defects. If there was an organomegaly, then think about IEMs. And if nothing comes positive, think about endocrinopathies. If the plasma amino acids, organic acids, ammonia, these are elevated, think about disorders of amino acid and organic acid metabolism. So this is broadly the approach for the hypoglycemia. So coming to the mechanism of hypoglycemia in the individual conditions, in prematurity and IUGR, there will be decrease in the hepatic glycogen and adipose tissue fats, because as we already discussed, the accumulation of this hepatic glycogen and tissue fat occurs only in the last trimester, because the babies tend to miss this, so they will not have enough stores to produce the glucose in the event of hypoglycemia. And there can also be a delayed maturation of enzymes necessary for gluconeogenesis, and reduced glucose 6-phosphatase activity and relative hyperinsulinism. So the insulin level will not fall as much rapidly as needed when the baby faces hypoglycemia. So in the infant of diabetic mother, so what happens in the intrauterine period, the glucose will cross the placenta by facilitated diffusion, whereas insulin does not cross. So to adjust the blood glucose levels, the baby only will produce the insulin levels. So because the mother was diabetic and does not have the tight glucose control, then the glucose transfer to the baby will also be more. So in the womb, the baby will be facing with the higher glucose levels. To balance that, the baby will be producing high amounts of insulin. So once the baby is delivered, So this maternal glucose supply from the mother to the baby will be cut off. So baby is already having a relative fetal hyperinsulinemia in response to the increased glucose supply from the mother. So after delivery, the combination of this fetal hyperinsulinemia, which does not go down immediately, and the lack of counter-regulatory hormonal response results in the hypoglycemia in the baby. So this combination also leads to the decreased hepatic glucose uptake and increased peripheral glucose uptake and impaired lipolysis. So thereby causing the baby to go into the severe hypoglycemia. So this is the flow chart, maternal hypoglycemia. So leading to the fetal hyperglycemia, fetal hyperinsulinemia. Sorry, this is maternal hyperglycemia, which transfers to the baby and becomes the fetal hyperglycemia, and leading to the fetal hyperinsulinemia. And this can also lead to the other conditions like relative surfactant like inefficiency. So in diabetic babies, there will be decreased functioning of the lung surfactant. That's why it goes into the relative respiratory distress syndrome more frequently. And increased metabolic rate and oxygen consumption can also lead to hypoxemia, thereby increasing the rate of stillbirths in infants of diabetic mothers once they cross certain period of gestation. And increased erythropoietin due to this hypoxemia, increased erythropoietin will be produced, leading to polycythemia, leading to jaundice. Increased metabolic rate and oxygen consumption will cause the macrosomia. So these are the mechanisms in the infants of diabetic mothers. So coming to the next one, hypopituitarism, in which there will be a growth hormone and ACTH deficiency. We will also note the midline malformations such as midline cleft palate, cleft lip, and nystagmus, which is due secondary to optic nerve hypoplasia, although this is not seen earlier than 6 weeks. And there will be a history of seizures. If we do an MRI, we can note the holoprosencephaly and these midline defects. And these babies are also prone for direct hyperbilirubinemia due to thyroid hormone deficiency. Micropenis and undescended testes in a male point towards a diagnosis of hypopituitarism. Secondary to the gonadotropin deficiency. MRI brain can diagnose the structural abnormalities like holoprosencephaly and midline defects. And glucagon stimulation test is diagnostic to diagnose the hypopituitarism. And growth hormone levels are also done. So thyroid hormone should not be replaced until the adrenal insufficiency is ruled out, because if we give thyroid replacement early, it can precipitate an adrenal crisis. Then coming to the congenital adrenal hyperplasia. So in this, there will be a ambiguous genitalia will be there, virilized genitalia in a female infant due to overproduction of adrenal androgens. This is the most common one is 21 alpha hydroxylase deficiency. There are others also, but I'm mentioning only the one which is secondary to 21 alpha hydroxylase deficiency. Classic presentation will be hyponatremia, hyperkalemia, and severe dehydration due to cortisol and aldosterone deficiency. Usually the babies present by 7 to 10 days of age. So how will we diagnose this? By doing the 17-hydroxyprogesterone levels on the newborn screening sample. And the treatment for CAH will be supplementing the hydrocortisone and fludrocortisone, as well as some sodium to maintain the sodium levels. And another cause for hypoglycemia is adrenal hemorrhage, which may occur secondary to maternal diabetes, secondary to fetal acidosis asphyxia. That's why in babies born born after the birth asphyxia, we do the ultrasound abdomen to look for adrenal hemorrhage also. So coming to hyperinsulinemic hypoglycemia, it can be secondary to KCNJ11 and ABCC8 gene mutations, in which the insulin production will be continuously happening irrespective of the blood glucose levels. And physical examination findings, we should look for macrosomia and syndromes associated with hyperinsulinism, like Beckwith-Widman syndrome or Turner syndrome. So, and glucagon challenge is usually given to see the glycemic response, in which IV or IM dose of glucagon 1 mg is given, followed by checking the blood glucose levels every 10 minutes for 40 minutes. A rise of more than 30 milligrams per deciliter in the plasma glucose is consistent with hyperinsulinism. So this hypoglycemia shows a poor response to diazoxide. The treatment will be local resection by focal or near total pancreatectomy. So transient hyperinsulinism is seen in IDM babies, asphyxia, preeclampsia, SGA, polycythemia, and RH incompatibility. They respond to the diazoxide. So coming to the treatment of hypoglycemia, if there is an asymptomatic hypoglycemia, first direct breastfeeding is the best option. If the infant is unable to suck, then expressed breast milk may be given because the breast milk promotes ketogenesis. Ketones are alternative resources for the brain along with pyruvate, free fatty acids, glycerol and amino acids. So then we should recheck the blood glucose after 30 minutes. If that shows improvement, frequent feeding should be continued. Formula feeds can be given if breast milk is not immediately available. There was one study, the sugar baby study in 2013, where they have tried the buccal 40% dextrose gel for asymptomatic hypoglycemia. So the dose is 200 milligrams per kg, which is applied to the dry mucosa, and the infant is encouraged to feed. Blood glucose level is checked after 30 minutes. This reduces the number of hypoglycemic episodes, recurrence rates, and the need to admission into NICU, and also increases the breastfeeding rates at discharge because these babies will not be put on formula feeds for subsequent hypoglycemia. So this has been shown to increase the exclusive breastfeeding rates at the time of discharge. Sugar fortified formula milk was tried, but this can compromise the breastfeeding rates. So we should be prudent before advising the fortification of milk with sugar. So it's better not to advise, either give direct breastfeeding or give plain formula feeds. So this is the AAP recommendation of the screening and management of the postnatal glucose homeostasis in late preterm and term small for gestational age, IDM or LG infants. Here, if you can see in the late preterm infants, that is between 34 to 36 6/7 weeks, and SGA infants, they recommend screening for up to 0 to 24 hours only. But previously we have seen in our Indian guidelines, it has been mentioned for up to 48 hours, and even 172-hour value was also recommended for small for gestational age babies. And in IDM babies and LGA babies more than 34 weeks, so the screening is recommended only up to 0 to 12 hours. So in this screening, if either the baby is symptomatic or the blood glucose was less than 40, symptomatic and less than 40, sorry, then directly the IV glucose should be given. If the baby is asymptomatic and the age is between birth to 4 hours of age, then we should give the feed within 1 hour and screen the glucose 30 minutes after the first feed. So if the initial screen is less than 25, feed and check again in 1 hour. If it is still less than 25, then we should immediately start the IV glucose. If the repeat value was 25 to 40, then we can refeed and then continue the screening. So, and decide for the IV glucose. So between 4 to 24 hours of life, if the baby is asymptomatic, so and the screen value is less than 35 milligrams per deciliter, we should feed the baby and check again in 1 hour. If the repeat value is also less than 35, then we should give the IV glucose. And if that is between 35 to 45, we can either refeed or give IV glucose as needed. So this is the recommendation of AAP. So the IV glucose is 10% dextrose given at the dose of 2 ml per kg. That is 200 mg per kg, which should be immediately followed by the IV infusion at an GIR of 5 to 8 mg per kg per minute to achieve a plasma glucose level of 40 to 50 milligrams per deciliter. So in symptomatic hypoglycemia, with blood glucose less than 40, so we should immediately start the IV dextrose. So the indication for giving IV dextrose is the inability to give oral feed, unable to maintain the blood sugar with oral feed, and severe hypoglycemia. So which will be started by 2 ml per kg and continuous infusion, and we will check the blood sugar after 30 minutes and then every 6 hourly until more than 50 milligrams per deciliter. We should ensure a continuous infusion because giving a bolus and then not giving a infusion may lead to rebound hypoglycemia, and we should avoid giving more than 12.5% dextrose through the peripheral line. The central line should be placed, either the umbilical line or the PIC line should be placed for the baby. So these are the formulas used to calculate the GIR. So the glucose infusion rate mg per kg per minute is equal to percentage of dextrose being infused and the rate ml per hour. So it's easy to remember formula D into rate by 6 into weight. So we can calculate if we know the weight of the baby and the flow rate which we are giving and the percentage which we are giving. If these three we know, then we can calculate the GR. So another formula is the mg per kg per minute GR, ml per kg per day, whether we are giving 60 ml per kg per day, 80 ml per kg per day, like that, into percentage of dextrose divided by 144. The third one is fluid rate ml per kg per day into 0.007 into percentage of dextrose being infused. So these are the different formula used for calculating the GR. This is the flowchart of management of a baby with hypoglycemia. According to our Indian protocol. So if the baby is asymptomatic and the blood sugar is between 20 to 40, try oral feeds and monitor the sugar after 1 hour. So frequent feeds, if it is less than 40, then we will go to the IV infusion and monitor the blood glucose sugars 6 hourly up to 48 hours. Before discharge, we should ensure that the mother is not having any feeding difficulty. If the baby is asymptomatic and the blood sugar is straight away less than 20, then we should give the IV glucose. If the baby is symptomatic, including the seizures, then we should start a bolus of 2 ml per kg followed by IV infusion at 6 mg per kg per minute and then 6 hourly. If the values are more than 50 and the baby is stable for 24 hours on this IV fluids, then we should try to wean the GAR by 2 mg per kg per minute every 6 hours. Concurrently, we should increase the oral feeds and monitor the blood glucose level 6 hourly. We can stop the IV fluids when the rate is 4 mg per kg per minute and the infant is stable. And we can also stop the glucose monitoring when two values are more than 50 on full oral feeds. If still on on GAR of 6 mg per kg per minute, if the blood sugar is less than 50, then we increase the glucose by 2 mg per kg per minute till the euglycemia is achieved. So we increase the glucose infusion rate until 12 mg per kg per minute. Then we should evaluate for persistent hypoglycemia and consider referring the baby to a pediatric endocrinologist and starting the baby on drugs like hydrocortisone, diazoxide, glucagon or octreotide based on the condition of the baby. So these are the treatment options available for persistent or refractory hypoglycemia. Hydrocortisone in a dose of 10 mg per kg per day, BD, IV. It reduces the peripheral glucose utilization, thereby increasing the blood glucose. Also increases the gluconeogenesis and increases the glucagon effect. Side effects being hyperglycemia and hypertension, we should monitor the blood glucose. Diazoxide in a dose of 5 to 15 mg per kg per day, TDS. So it is a potassium channel agonist. Its side effects being fluid retention, hypertrichosis, and cardiac failure. It can be used in a combination with the hydrochlorothiazide, and diazoxide and glucagon should not be used in SGA infants. Octreotide is used in a dose of 5 to 35 micrograms per kg per day, thrice daily dose, subcutaneous. It's a somatostatin analog and inhibits the insulin secretion. Side effects are cholelithiasis, transient growth impairment, and tachyphylaxis. Glucagon 0.2 mg per kg, subcutaneous or intramuscular. Mode of action is by glycogenolysis and increased gluconeogenesis. It may cause nausea, vomiting, skin rash, or rebound hypoglycemia. There are other newer treatment options like mTOR inhibitors like sirolimus and everolimus. More studies are needed for these drugs. The dose is 0.5 milligrams per meter square per day in 2 divided doses, targeting a drug level of 5 to 15 nanograms per ml. They act by inhibiting the insulin production. And for persistent hyperinsulinism, surgical treatment like near total pancreatectomy should be considered after 18-fluoro L-DOPA scan to detect the focal lesions in the pancreas. Coming to the follow-up after hypoglycemia in babies, how will be the long-term outcome of these babies? So the brain glucose is naturally also 30% lower than the blood glucose. So Glucose is required for the neuronal computation, information processing, and maintaining the ion gradients across the neuronal membranes. Glucose enters the brain through GLUT1 and GLUT3 receptors, leading to the generation of the glutamate vesicles, which help in the production of the ATP. So this is the normal functioning of the glucose in the brain. So whenever there is any hypoglycemia, the brain is unable to access enough glucose, then it leads to abnormal release of glutamate and aspartate, which increase the reactive oxygen species from the mitochondria and increased production of the zinc into the extracellular fluid. Zinc is also an excitatory neuromodulator. So these reactive oxygen species and excessive zinc, glutamate, and aspartate help they damage the neuronal membranes. So the predilection for injury after hypoglycemia is mainly for the parieto-occipital regions and the posterior part of the corpus callosum and the splenium. So in babies who are less than 6 months. So the long-term effects are developmental delays, seizures, decreased IQ, reading and arithmetic proficiency, visual processing mainly, and cognitive difficulties. So that's why we should check the visually evoked responses in babies who faced with the severe hypoglycemia. So, but the outcome depends upon the duration of severe hypoglycemia, degree of hypoglycemia, the rate of cerebral blood flow, and the other comorbidities which the baby had, like asphyxia or sepsis. We should regularly follow these babies at 3, 6, 9, 12, and 18 months for hearing, vision, and developmental assessment. So this was an MRI of a baby who had a severe hypoglycemia. Here we can see in the posterior part of the occipital lobe in the first image, showing the lack of the cortical differentiation. So here we cannot see the gyri and the sulci in the one axial T2 weighted imaging showing an extensive cortical and subcortical damage mainly in the occipital lobes with lack of differentiation. The second one is the diffusion weighted imaging in which there is a large posterior subcortical area of reduction of apparent diffusion coefficient. So again MRI was repeated after 5 weeks of age. Here we can see atrophy of the occipital areas more extended in the left occipital lobe. So this is the predilection for hypoglycemic brain injury in the posterior parieto-occipital regions and the deep brain structures. So the fourth one is DWI image showing an increased water diffusion in the affected areas and a smaller cavitation. So this is the typical MRI of a baby after an hypoglycemic brain injury. So among the outcomes, there was a study called the child study, children with hypoglycemia and their later development study. In this 404 neonates who were born as term and late preterm neonates at risk for hypoglycemia were studied. Hypoglycemia was defined as a blood glucose concentration less than 47 milligrams per deciliter. If the baby was noted to have blood glucose less than this value, baby was treated with a combination of additional feeding or buccal dextrose gel or intravenous glucose. And then the developmental assessments was done subsequently at 2 years of age and 4.5 years of age. So the components which were tested was any developmental delay with BSID cognitive or language composite score of less than 85 and motor impairment, cerebral palsy, hearing impairment or blindness. These were the components which were tested. So there was, if the blood glucose level was maintained at 47 milligrams per deciliter, there was no association between these temporary hypoglycemic episodes and neurosensory impairment at 2 years of age. Means there was no difference between babies who had hypoglycemia and babies who had a normoglycemia. But at 4.5 years of age, they noticed an increased risk of poor executive and visual motor performance. So at a later stage, there will be visual defects and executive performance like arithmetic skills and cognitive skills will be affected at a school going age. So we should be very careful to avoid the hypoglycemia in the neonatal period, and this risk will be up to 50%, which can be more than asphyxial insult also. So I'll just give one example of this baby who was born as a 37 weeker in our unit with a birth weight of 2.321 kgs. This was an SGA IUGR baby. Baby got discharged. Baby was on exclusive breastfeeds. Baby was born to a primary mother. So they had not given the feeding properly, and then the baby was brought with dull activity and seizure-like movements on day 5 of life. The baby's admission weight on examination was 1979 grams, which was showing 14.7% weight loss. That means inadequate feeding only. Primary mother with SGA baby. So the infection parameters were ruled out. Sepsis, screen, blood, CSF were all negative. On doing the MRI, there was a T2 flare hyperintensity and T1 hypointensity with restricted diffusion on DWI unilaterally, which was suggestive of unilateral hypoglycemic encephalopathy. On developmental follow-up, up to now, the baby is doing fine, but we have to see the long-term follow-ups. So this is an example. A baby 3 weeks old comes with decreased feeding and dull activity. There was hypoglycemia. On doing X-ray, there was a cardiomegaly. Baby had poor cardiac function also, like cardiomyopathy. Arrhythmias were also noted. Baby was noted to be hypotonic and had organomegaly. So 3-week-old baby on feeds comes with this picture with hypoglycemia, organomegaly, hypotonia. So we definitely think of inborn errors of metabolism. So then the ketones were done. Ketones were normal and lactates were high. So on doing the newborn screening, the acyl carnitine profile was high. So this was diagnosed as long-chain fatty acid oxidation disorder. So how do we treat this? By giving frequent feeds and low-fat formula and medium-chain triglyceride supplementation. Now we'll discuss briefly about hyperglycemia, which is also injurious to the brain as much as the hypoglycemia. So what is the definition of hyperglycemia? Any whole blood glucose more than 125 milligrams per deciliter or plasma glucose more than 145. So hyperglycemia leads to hyperosmolarity because every 18 milligrams per deciliter increase in the blood glucose increases the serum osmolarity by 1 milliosmoles per liter, which may lead to osmotic diuresis and dehydration in premature babies. And it may also lead to because of this hyperosmolarity, it may lead to contraction of intracellular volume of the brain and may also cause intracranial hemorrhage. What are the causes of hyperglycemia? Mostly iatrogenic causes like infusing the concentrated dextrose solution and drugs like steroids, caffeine, theophylline. These are regularly used in the preterm babies, and phenytoin and diazoxide doses without properly monitoring the blood sugar levels can lead to hyperglycemia. And in ELBW babies, there can be a hyperglycemia because of variable insulin response and insulin resistance and hepatic glucose production. Lipid infusions in TPN can also increase the glucose levels. And any like sepsis conditions can increase the glucose. Sepsis causes hyperglycemia because of decreasing the insulin release from the pancreas and increasing the cytokines and endotoxins, which cause decreased glucose utilization. Elevated stress hormones in babies on mechanical ventilation and babies having pain like frequent suctioning and any skin injury and post-surgical babies, they all have the hyperglycemia. Hypoxia also leads to hyperglycemia and giving hyperosmolar formulas. There is an entity called neonatal diabetes in which there may be a family history of diabetes and baby will have marked hyperglycemia, glycosuria, polyuria, severe dehydration, acidosis and failure to thrive. So on examination, these babies will have low or absent insulin. This is due to mutations in the KCNJ11 and ABCC8 genes. So what is the treatment for hyperglycemia? Adjusting the GIR, giving less GIR initially with starting with 4 to 6 mg per kg per minute, aggressive TPN, providing early amino acids, not only giving only fluids. And if hyperglycemia is more than 250, then we can treat with insulin. So insulin like can attach to the plastic tubing. So we should flush the tubings twice before starting an insulin infusion. Insulin infusion can be started at 0.05 to 0.2 units per kg per hour, but we should be frequently monitoring the blood glucose level so that the glucose does not become low. And a Cochrane review was conducted in very low birth weight babies where prophylactic insulin use was associated with increased mortality at 28 days. So whenever we are giving insulin, we should be very careful to monitor for the hypoglycemia. So that was the today's topic of hypo and hyperglycemias. Thank you all for your patient listening.